Good evening, dear colleagues. First, I would like to thank organizers for the invitation and for acceptance of our abstract. I have no conflict of interest to declare. The ongoing management of HIV aims to improve physical and psychological well-being and thus health-related quality of life. Also, very little is known about well-being of AIDS drug addicts living with HIV in Ukraine. So we aim to assess a health-related quality of life of people living with HIV who inject drugs and attend in regional cardiological clinic in Sumy, Ukraine, and healthy blood donors in order to identify the ways of its optimization and improvement. We conducted cross-sectional comparison parameters of well-being and defined 3 study populations: older group aged above 55 years, younger group, and population reference, healthy blood donors. All HIV-infected participants had no active manifestations of opportunistic infections and were retained in care. Concerned participants were interviewed to collect socio-demographical and behavior-related data using a study-specific case report form. Health-related quality of life was assessed using a specially developed questionnaire that includes combination of subjective and objective approach. The part of questionnaire for patient included closed-ended questions to assess dimensions in physical, social, and spiritual component of health. The second part includes objective criteria from healthcare provider perspective with general health status, emotions, physical activity, ability to work, and presence of comorbidities. The 3 study populations were well matched except for the family status and educational level. Participants were mostly males with urban residence, and as we can see, a majority of HIV-infected participants of both age groups received antiretroviral therapy and opioid substitution therapy. The summary score of health-related quality of life for older group was lower compared to population reference and people who inject drugs from younger group. In general, 60% of aged drug addicts living with HIV, 85% of people who inject drugs in younger group, and 90% of donors were satisfied with their health status. Physical component of health was similar among all 3 study populations. There was no evidence for a difference in this index, while social component of health was, median score of social component of health was lower for aged people who inject drugs compared to donors and younger group, and the same situation for healthcare provider pattern. Spiritual component of health was lower for HIV-aged people who inject drugs living with HIV compared to population reference, but did not differ for HIV-infected participants of different age group. In conclusion, to our knowledge, this is the first report of quality of life in aged people who inject drugs living with HIV in Ukraine. The quality of life in this category of patients remains lower than in general population and younger group. And the low level of well-being in these patients is largely due to social and spiritual component of health, so an adequate access to social support and mental health care should become a key priority for this category of population. Of course, the most important limitation is the cross-sectional nature of the study. Also, these findings may not be generalizable to other studies with validated instruments or to non-injecting cohorts. Finally, we would like to express our deepest appreciation to our colleagues from Regional Oncological Clinic and our special thanks to all patients and donors for their participation on this study. Thank you very much for your attention.